This meeting is now being recorded.
Good afternoon, everyone. My name is Rana Suleiman, Program Director at Grantmakers in Health. Thank you for joining us for today's webinar, How Medicaid Supports Trauma-Informed Care for Children. Before we begin, I have a few logistics and housekeeping notes. Our call will be an hour long. The webinar is being recorded and we'll post the recording along with the slides and additional resources to our website next week. At the end of the webinar, we'll be answering questions from the audience. You can enter your question into the chat box feature, which is located in the lower left-hand corner of your screen. We'll be reading those questions aloud. In today's webinar, we'll be reviewing the impact of childhood trauma and exposure to adverse childhood experiences, or ACEs, on overall health and well-being. We'll discuss the current behavioral health and trauma services covered by the Medicaid benefits package. We'll highlight examples of state-based best practices and innovative policy initiatives, and we'll explore future opportunities to improve Medicaid's response to children exposed to ACEs and other forms of trauma. I'm now pleased to welcome our featured speaker. Kamala Allen is the Director of Child Health Quality and Vice President of Program Operations at the Center for Healthcare Strategies. Kamala has extensive experience in the use of managed care in public child serving systems, and we're thrilled she's joining us today. Kamala, the floor is yours.
Thank you so much, Rana, and thank you everyone who has been able to make the time to join us this afternoon. I am so excited to be presenting to you today, especially around a topic that is so near and dear to me and to many of us at CACS and certainly our Child Health Quality team. So I'm going to kick it off. Hopefully everyone sees the slide advancing. And as Rana said, the focus of today's presentation is really around how we can use Medicaid to support trauma-informed approaches to care, specifically for children. We're going to start off with a high-level overview. We're going to talk a little bit about the opportunities that Medicaid offers to support trauma-informed care, and then end with what states are doing to leverage those opportunities through Medicaid. I look forward to your question and answer, and look forward to sharing some robust resources with you at the end of the presentation. I just wanted to acknowledge my colleagues, Meryl Shulman, Melissa Bailey, and Pamela Tu, who have contributed to the content for this presentation, and also comprise members of our Child Health Quality team. So I just wanted to have an opening slide here for folks who may not be familiar with the Center for Healthcare Strategies. The organization was started in 1994 with an initial grant from the Robert Wood Johnson Foundation. Since that time, we've moved from a two-story house in Princeton, New Jersey, to an office park in Hamilton, New Jersey, right next to the New Jersey Transit train station. So if you ever are on the New Jersey Transit or even Amtrak and you hear them talk about Hamilton, you are probably passing our office. Our team is a staff of about 56 people, and the three areas in which our work is organized is integrating care for complex populations, which is where our Child Health Quality team sits, leadership and capacity development, where we work with state agencies to improve leadership and develop leadership of state programs, primarily Medicaid, but also on our Child Health Quality team, we work collaboratively with our leadership and capacity building team for the support of child welfare leadership. And so that's an exciting portfolio of our work. And then delivery system and payment reform, which certainly touches all of the work that we do. So I want to stop talking about myself and CACS and say a little bit about the content that we want to get into. So one of the things that we've seen in the past few years is an increasing awareness of childhood trauma. As Rana said, this is also referred to as ACEs, or adverse childhood experiences. That comes from a research study that was done in California, Kaiser Permanente, and has had very, very long legs, and in recent years has really become a bellwether for many states, for many advocates, and certainly for those who are involved in serving children and families. And so some of you may have seen a piece that Oprah did last year on 60 Minutes in her new role there, where she talked about ACEs and childhood trauma. And we feel like that was really a turning point in terms of increasing awareness of this issue. When we talk about ACEs, we really are thinking about experiences that impact children during a critical part of the life course. We know that trauma can occur at any point during the lifespan, but when it occurs and it occurs repeatedly during childhood, it has an impact on the developing brain. And so I wanted to include this screenshot from a YouTube video, and I've included the link because I think it's really a very powerful graphic representation of how trauma and ACEs impact children and how there are ways to mitigate the impact of that trauma. So if you have an opportunity to look at that video, I would highly encourage you to do so. So I've used a few terms to this point. I've used trauma, I've used adverse childhood experiences, and the thing to really understand is that oftentimes those terms are used interchangeably, but trauma, as I mentioned, can occur at any point during the lifespan, whereas adverse childhood experiences are really those traumatic events that occur during childhood. And so when you are in this space or you bump into folks who do work in this space, I just wanted to give you a little bit of kind of the terminology so that you would understand that adverse childhood experiences really are trauma, but during the childhood years. One of the important things to know about adverse childhood experiences is that, as I mentioned, it can occur during any part of the lifespan, but they also occur across all groups, racial, ethnic, social, economic, all groups. And so while folks may be thinking in the context of Medicaid that ACEs is a Medicaid-specific issue, it really is not. It's a human issue. But Medicaid offers us particular levers and opportunities to be able to address it for individuals who are Medicaid beneficiaries. And so I'm assuming that most folks understand kind of the broad strokes of the Medicaid program, which is that is a health coverage for individuals primarily who are low income, but also individuals with disabilities. And when it comes to children, it also is a eligibility pathway to the Medicaid program that's provided through the foster care program. And so when we get to some of the later slides in the deck, I'll go into a little bit more detail about that. But the key point here is that there are certain groups that are at higher risk for experiencing ACEs, but that ACEs are universal. And so when we think about the strategies that can address ACEs, we should think about the levers that we have available given the individuals that we want to target or address. So the next couple of slides are pulled from a study that was the National Survey of Children's Health Study. And it really was looking at, when we think about ACEs, what are the types of ACEs and how frequently are those occurring in children? And so you see the top three bars show that just over 50%, just over half of children did not report ACEs. And this is a parent report, that just about a quarter reported one ACE, and there were 2 or more ACEs reported to just under a quarter. So just about 1 in 5 individuals reported 2 or more ACEs. The next set of bars describe the types of adverse childhood experience. And you can see that the most frequently cited childhood ACE is economic hardship or poverty. And we know that poverty is associated with a number of other social determinants of health, so housing and food instability specifically. Some of these others, I'm sure, are things that you could imagine even without this presentation would likely be considered adverse childhood experiences. And so you'll see things here like parental divorce or separation, substance use within the household, incarceration of a parent, mental illness, domestic violence, community violence, racism, and death of a parent or guardian. So I don't think that those are likely to be surprising to anyone. And this next slide, I just wanted to give a geographic representation. And again, this is information from CAMI, so the Child and Adolescent Health Measurement Initiative. And they looked at how frequently ACEs were reported and looked at the high and low. So you can see that Minnesota was reported to have the lowest percentage of ACEs nationally, and Arkansas the highest. So again, just wanted to share that because I know a lot of funders have geographic priority areas. And so for any funders that might be interested in this issue, I thought this might be a nice piece of information to have. So I want to ask our first polling question. And the poll question is, are you familiar with the Adverse Childhood Experience Study? And I'll turn to Rana to walk us through the poll process. Rana?
Sure. So we'd like all participants to please enter their response to the question in the chat box. And again, that is located in the lower left-hand corner of your screen.
Okay. So we've got a good number of responses, mostly A's and yeses. A couple people who may not be familiar with it. So I'm going to just give a little bit of information about that study. And so in the late 90s, Kaiser Permanente members, so this was a commercially insured population. Kaiser is a integrated health system. So if you're a Kaiser member, I'm actually a Kaiser baby born in a Kaiser system. All of your healthcare services are provided in that one umbrella. So all the members, so you basically can go into one building and have radiology and have your primary care physician and have your specialist all in one building, as opposed to a system that has a network of providers, but those network providers are not employed by that one healthcare system. They may be participants in a number of provider networks. And so there were two waves of this study for a total of 17,000 members who participated. The categories of adverse childhood experience were listed, specifically those that were associated or looked at for those that were associated with the leading causes of death in adults. And those are listed here, and you'll see that there is a lot of overlap between those that we described on a previous slide. And so when you look at the results of that study, just about 2/3 of those study participants reported at least one ACE, and more than 20% reported 3 or more. And so I've listed here and I probably should have done this in descending order. So the most frequently reported ACE in that study was living with, and this is, I know, not the language that we would use now, but now at the time of the study, it was living with a substance abuser. That's actually kind of hard to say. So living with an individual who experienced substance use disorder, and then experiencing sexual abuse, living with a household member who had mental illness or was experiencing suicidal tendencies. And then it kind of goes down from there after domestic violence, or specifically violence against the mother. What we know from this study is that when you get to 4 or more ACEs, is where you really start to see the impacts on health. And so the specific health-related conditions that were associated with individuals reporting 4 or more ACEs are listed on the slide. So COPD, sexually transmitted infections, smoking, suicide attempt, alcoholism, and the injecting of street drugs. And again, this is from a study that was done in the late 90s, so the language is a little bit different than what we would use today. And so what we know about ACEs and the impact on health is that there is a stepwise increase or a graded dose response. So in other words, the more ACEs an individual reports, the higher their risk for negative health outcomes. So that's kind of a daunting story. As we know, we can't prevent all ACEs. And so if we want to think about the fact that we know that there are going to be negative experiences that individuals face, what can we do to try to mitigate those or help them heal from those? And so that's the story of resilience. And so I love this graphic. And so what it basically says is we can't, stop the dragon from breathing hot fire on us, but there are ways that we can, in some ways, mitigate the impact or the result of that fire. And if we can just kind of have tools and resources to surround us or to protect us, then those things don't last forever, and there's an opportunity for us to heal from those things. When we think about the factors that support resiliency, there are a couple of specific categories of factors that we want to highlight, and that's in it. And you'll also see this if you look at the video that I shared, the YouTube video. And at the top of that list is a relationship, and that's probably not a surprise to anyone. We also know that there are a number of social determinants of health. So we talked about housing and food instability. Those are things that may be present in the communities in which we live, but we know that there are programs and resources provided by community-based organizations, state agencies, federal government that are intended to help address and ameliorate some of those concerns, if not be able to eliminate them altogether. And then there are things within us as individuals that may contribute to the resiliency. And so some of those are listed below. So when we think about this specifically in a healthcare context, we start to move away from just the concept of trauma and ACEs overall, but thinking about a response to that is trauma-informed. And so this is the definition of trauma-informed care put forward by SAMHSA, which is the Substance Abuse and Mental Health Services Administration, part of the Federal Department of Health and Human Services. And one of the lines that you will always hear anyone who does work in the ACEs space and trauma more broadly, so across the lifespan, is to reorient our thinking about the people that we're working with from asking what's wrong with you to asking what happened to you, and putting the behaviors that we might see them exhibit into a frame that helps provide context for those behaviors, and then seeks to try to create supports that are healing and that don't further traumatize those individuals. This slide is just to show what SAMHSA has put forward as, I mentioned on the other side, the resiliency slide, that there are some things in the environment, and there are some things that are also intrinsic within us as individuals that help mitigate ACEs, on a personal level, but we also are impacted by the systems within which we serve, or we work, we serve individuals, or as people seek out services. And so there is a concept of a trauma-informed organization. And so one of the things that is really happening now is that there is a corresponding focus on trying to increase the trauma sensitivity of organizations and making them trauma-informed at the same time that we provide trauma-informed care that may be a specific medical or social service. And so these are some of the principles associated with a trauma-informed organization. And so there's work that we've done at CHCS, working with a number of grantees to help them implement trauma-informed organizations. There are a number of communities across the country that are doing this work. And so I just wanted to share this with you as you think about your own organizations or those organizations that you work with. This slide is really intended to show that there are some key areas of opportunity when we think about mitigating the effects of ACEs, trauma and ACEs specifically. So if we are thinking about this beyond children, we are thinking about still the individuals around us in the context of children. We are thinking about parents and caregivers. So you see that at the top of the circle. We know that the service professionals that we work with or that we seek services from or support from need to be trauma informed. And so we need to provide training and professional development to ensure that when they engage with individuals, children, and families that have experienced trauma, that they don't further traumatize them. We want to go out even more broadly and then think about what the community is doing. So are there resources in the community when we think about our community policing, when we think about the way when people come into the healthcare system, the way that they're greeted, what those environments look like, how they are positioned vis-a-vis the power dynamic within those interactions. So we think about how we promote community awareness of ACEs. When we go out to the next level, we think about policy. And so I mentioned that there's, both local, state, and federal policy that has been put forward to try to advance ACEs. There are a number of grant programs that are supporting ACEs policy development and thinking about how we bring together systems that are serving children and families and have a more holistic approach to supporting children and families in non-traumatizing environments. And then finally, thinking about how we provide opportunities and funding for research and learning so that we can continue the cycle. So folks are familiar with the concept of continuous quality improvement. We know that we're constantly looking for information that lets us know whether the things that we're doing, the interventions we put in place, are having the desired effect and impact or not. And if they are, we want to continue doing those things. And if they're not, we want to go back to the drawing board and iterate and make sure that we're addressing those things that may be preventing us from having the desired impact. And certainly one of the key inputs to that is hearing from children, families, and folks who are working in the system that support them. I want to go to the next slide where we have one more poll. So given the slide that we just looked at, which I'll go back to for just a second, because this is a group of funders, I thought it might make sense to ask you to think a little bit about your funding priorities, your organizational priorities, and whether there are specific aspects of this circle, these 5 areas of opportunity that would resonate with you specifically given your funding priorities. I'll go back to that poll. And so first is supporting parents and caregivers. And certainly, let me just be clear that I'm not suggesting that any one organization could not do all of these things. But just asking you to just pick one that's most aligned. So again, supporting parents and caregivers, training service professionals in trauma-informed care practices, promoting community awareness, advancing policies that support trauma-informed care, collecting, analyzing, and sharing research and learning.
And again, please enter your responses in the chat box.
Thank you, Ron. I was on a roll. I did your part. Sorry about that.
My part, that's fine.
I see a lot of B's, a lot of training, see some support for parents and caregivers as well. One supporting community or promoting community awareness. Great. Thank you. Thank you for your input on that. So the next section I wanted to move to is about the money. And so we know that there are a lot of promising models out there, but unless we have the ability to finance those models and sustainably finance them, it's a very challenging endeavor to try to create a system that supports children and families in an ongoing way. And so I want to talk a little bit about the dollars and talk specifically about Medicaid's role in that. And so here's why I said I wanted to just give a little bit of an overview of the Medicaid program. I know some people may be familiar with this, so if you are, please read along with me. But the Medicaid program was established in 1965. It's an entitlement program, meaning that if you meet the eligibility requirement, you must be provided benefits under the program, as opposed to there are some programs, some federal programs that have waiting lists and have caps on enrollment. CHIP has been a program that has suffered from that, but Medicaid is an entitlement program. So basically, if you meet the eligibility requirements, you are enrolled in the program. The Medicaid program is a jointly funded federal and state program. So there's a federal share that's contributed each year, each fiscal year, based on the state's FMAP. And so there is an algorithm that the state uses, and it's based on per capita income. And so what you will see is that the states that have the lowest per capita income have the highest federal contribution, and those states that have higher per capita income have lower financial contributions. And the FMAP currently ranges from 50%, a low of 50% to a high of 83% across the states and territories. The territories are also participants in the Medicaid program. I know some people don't realize that, so I just want to point that out. So this slide is intended to give you a sense of what the the distribution of the enrollment is across the age span and across the eligibility categories, and what the corresponding proportion of the Medicaid budget is. And so the key takeaway here is that while children, and this was as of fiscal year 2015, were the largest single enrollment group, they only account for a little less than 20% of the program. It's probably not surprising that individuals with disabilities, which are 15% of the program, account for the largest proportion of the class. But just wanted you to have a view to that. And you'll see that there are two categories, the newly eligible adults and non-newly eligible adults, which are adult populations that are not aged or blind or disabled, which is the other category, those top two categories. And so for those states that enacted Medicaid expansion, that 9.1 million is that population, those newly eligible adults as a result of the ACA or the Affordable Care Act. The next slide, want to give you a little bit of information about what the child Medicaid population looks like. And so CHDS has been doing a series of Medicaid analyses over the last several years. Our focus really has been looking at children's behavioral health, but we have done the broader analysis of looking at the entire child Medicaid population and then drilling down around the utilization and expenditures associated with behavioral health services. And so the key takeaway from this slide is that we've seen more than a double-digit increase in the proportion of children enrolled in the Medicaid program from 2005 to 2011. Actually, we're just beginning to embark on the study looking at 2015 data. If you're at all familiar with Medicaid claims data, there is a significant lag. And so while the 2011 seems dated, we are just getting to the point where we have the majority of states reporting their 2015 Medicaid claims. The next slide just shows you a little bit about the distribution of children in Medicaid by age category. And so the largest proportion of children in the Medicaid program are eligible by virtue of income. That's temporary aid for needy families, or TANF. The children who are eligible by virtue of disability is the next largest group, but significantly lower at just 5%. And then the smallest proportion are children who are eligible by virtue of their foster care status, which is just under 3%. And again, this is 2011 data. We know that these numbers have gone up since 2011, but appear that they are on the way back down in terms of the number of children entering foster care. And I'll say a little bit more about that bump later. And then here I wanted to provide the analysis by age, because I know some funders are focused on early childhood, others look at adolescence. And so I just wanted to give a little bit of visibility to what the distribution is across the age spectrum. And so young children, 0 to 5, are the largest age cohort in the Medicaid program, followed by the school-age children and then the older adolescents. That one. Okay. So the Medicaid program, I told you that the Medicaid program was established in 1967. 2 years later, there was a specific child benefit that was implemented as an amendment to the Social Security Act, and it's called EPSDT, Early Periodic Screening, Diagnosis, and Treatment. And so you often hear people refer to EPSDT program or the child benefit. It is this benefit. And it really is designed to help to identify any health-related issues as early as possible, and to ensure that once those concerns were identified, that there was treatment made available to ensure that to the extent possible, that condition did not deteriorate. Recognizing that some conditions, the best that you can do is to keep it from getting worse. In some cases, we can resolve those things and cure things, but in some cases that is not the goal. So the APSDT program is a very comprehensive benefit that every child who's enrolled in the Medicaid program receives. So it's not a specific program they have to enroll in. It comes along with their enrollment in the Medicaid program. And so this slide is just designed to give a little bit of a visual of what the various components are under EPSDT. And so you see the acronym at the bottom, and it talks about that early identification that I mentioned. The periodic really has to do with age-appropriate well-child visits. Most folks are familiar with well-child visits, which happen very frequently up to age 2, and then annually for a period of time thereafter, up to age 20. Screening, as I mentioned, identifying those needs early, determining diagnostic services and assessments, determine what needs to happen to ameliorate or correct those, control those, and then ongoing treatment. The one other thing I just want to say about the Medicaid program is that, that folks always say, if you've seen one Medicaid program, you've seen one Medicaid program, and that's because the federal government, in the law, in the legislation, in the statute, there are specific services that must be provided, but then there are also optional services, and so every state has the ability to determine which optional services it is going to include in its Medicaid state plan. So that is why every program is somewhat different. So tying this back to funding for trauma-informed care, you see Medicaid at the top of this list because we're going to go into more detail on that. But I did want to provide a slide that gave a little bit more context about the very many funding opportunities or vehicles or venues for trauma-informed care. And so I've listed just a few examples for a number of those. Many of those we'll see in child welfare, education, and behavioral health. There are a number of philanthropic funders. The New Jersey Funders ACES Collaborative, which is a collaborative of 3 New Jersey grant makers, has committed over $2 million to help the state of New Jersey become trauma-informed and to develop a statewide action plan to help New Jerseyans, to prevent, protect, and heal from ACEs. Commercial insurers also have a role to play. So when we think about some of the, for example, parity requirements, making sure that there is equal access to behavioral health services as there are to physical health services. So there are a number of pathways to identifying resources to support trauma-informed approaches to care, both in terms of services and other community support. So I wanted to just share this survey that was done by National Child Traumatic Stress Network, and they outreached to members of that network to find out how they were funding trauma-informed services. And you could see that Medicaid was the highest funding source. And let me just say, when it says non-NCTSI, so there are dollars that go from the federal government directly to the National Child Traumatic Stress Network and their initiative. And so taking those dollars off the table, these are the funding sources. And of those, Medicaid was the most frequently reported funding source used to provide trauma-informed services. It was also, in another survey question, I didn't include all of them, identified to be the most stable, because as I mentioned, Medicaid eligibility, EPSDT, once you're eligible, you have access to those services, as long as they're included in that state plan. The next slide shows the other side of that story, which is that Medicaid is not always easy to access from a reimbursement perspective. And so just to remember that Medicaid is a financing mechanism, and those dollars are drawn down through reimbursement by the state. And so the state has to expend dollars first, or Medicaid provider has to expend dollars first, and then they are reimbursed by the Medicaid program. And so you see at the top of the list is difficulties with those reimbursements. There is a lot of documentation that's required to ensure that there is no fraud and abuse. And so many of those things can be challenging, particularly for community-based organizations who may not have a very sophisticated fiscal infrastructure. So on this next slide, I wanted to say a little bit about a number of the administrative vehicles that the Medicaid program offers. So you'll see here listed state plan amendments, which I've mentioned, Medicaid waivers, managed care contracts, and integrated care models. So the state plan amendments, as you heard me say a little while ago, that each state has its own plan, and that plan defines what services that program is going to potentially will be seeking reimbursement from the federal government to draw down that FMAP, or that federal percentage of the expense. And so health homes and state plan-based home and community based services are two types of services that can be included in the state plan. When something's in the state plan, that means everybody who's eligible for the program has access to that service. That's different than the next category, which is Medicaid waivers. Medicaid waivers require the state to define the population that is going to receive those services. And the waiver is a reference to the fact that it waives the right or the requirement that the state has to provide every service to everyone in the program. So that's the primary distinction between state plan amendment vehicle and the waiver vehicle. Managed care contracts, many of us are probably familiar with those because we may receive our own healthcare services through managed care contracts. And so there are states that have contracted with managed care organizations, in some cases, to create specialty care management programs. And in those cases, those managed care organizations can define very customized, tailored, or unique services that they will agree to that they will provide, and it's not always because the state is asking them to. So in some cases, you have managed care organizations that have identified a particular population or a particular condition that they want to target, either as a program improvement type of initiative, or because there's some passion that someone in leadership in that organization has around that condition or population. In other cases, it is driven by the state, where a state has said, okay, for the next 3 years, our Medicaid program improvement initiative is going to focus on XYZ condition. It could be asthma, it could be diabetes, it could be addressing trauma. And so there are opportunities to leverage those managed care contracts to address trauma in the population. And then finally, integrated care models. And the most popular one at this time is accountable care organizations. And accountable care organizations are vehicles that are entities that have been created, basically pulling together a healthcare delivery system that is designed to meet the needs of the community, and all of the services and supports that that community needs or that population needs are included in that accountable care organization. And there's a shared fiscal responsibility for meeting the needs of that population within whatever that budget is, whatever that agreed upon fiscal mechanism is for that ACO. And there are financial incentives that are provided from the state to those organizations for managing the outcomes, the healthcare outcomes of that population and the cost. So those are some of the vehicles that the Medicaid program makes available that can be leveraged to address trauma-informed care. I talked about EPSDT earlier, and so I just wanted to call out a few very specific ways that the EPSDT benefit can be used. So screening, assessment, and treatment, you'll recall those from that earlier slide. There are trauma-informed screening, assessments, and treatments, all that exist currently. And the EPSDT benefit can be used, the codes for screening, assessment, and specific treatment services can be leveraged to provide trauma-informed versions of all of those things. And so there are a number of trauma-informed screening tools that states are reimbursing for. In many cases, when a provider is using trauma-informed versions of these of screening and assessment tools, the state will pay a premium, or the managed care organization, if it's in a managed care context, will pay a premium on top of the basic rate for that code. And so there's typically a modifier associated with the basic screening code that would indicate that it is trauma-informed, and therefore draw down those additional dollars. So there are ways that we can provide financial incentives to move forward that trauma-informed agenda. The next opportunity under Medicaid is for provider training. And so the Medicaid program does not allow reimbursement of expenses associated with provider training for a provider to become a Medicaid provider. They have to be qualified to become a Medicaid provider and go through a credentialing process. but once they have been credentialed as a Medicaid provider, they can draw down additional dollars, administrative dollars, to for training, and that training could be to include some trauma-informed components in whatever the state currently requires for training for maintaining that credential. There, in some cases, states, I know New York State, for example, has a statewide training program specifically for trauma-informed care. They also have one for folks who are familiar with SBIRT, screening, brief intervention, and referral to treatment, which is something that can also be synergistic with this. It is a prevention program, or early intervention and prevention program around adolescent substance use. And so there are a number of states that are thinking about how to marry some of those initiatives that maybe have been going on in their states for a period of time with this new focus on trauma-informed care. Here on this slide, I've listed a number of other services that can be leveraged to address trauma within the family system. So respite, for example, is a Medicaid covered service, as is what's typically been referred to as mobile crisis, but is now more typically referred to as mobile response and stabilization, peer support, and telehealth. And I just gave a couple of examples at the bottom of the slide of some of those, how they might be used to address trauma within the family. And then I wanted to get to kind of what I think is the highlight section of the presentation, which is what are some of the states doing that are currently using Medicaid as a reimbursement mechanism to address trauma. And so this is another quick poll. And this one I'm going to turn to Rana to introduce to you.
Yeah, so again, we'd like to ask you to enter your response into the chat box. And this question is, are you aware of any state efforts that use Medicaid funding to address childhood trauma? A is yes, B is no. And again, please enter your response into the chat box.
Yeah, thank you for your responses. So this next section, as we had hoped, is going to be hopefully illuminating to folks, because most people are saying that they're not aware of any of these efforts specifically to address trauma. The first one I want to raise up is health homes. So health homes is a provision, a new organizing mechanism for delivering services under the ACA, designed to support individuals with chronic conditions, multiple chronic conditions. In New York State, they're using the health home provision to address behavioral health needs in one of their health home programs, and they've specifically included complex trauma as a qualifying condition. And so, as I mentioned, trauma is kind of the across the lifespan construct. And so health homes do not allow you to target by age. So the fact that this is a health home provision or qualifying condition means that there are health homes in New York State that address trauma in both children and adults. And so the providers who are serving children are likely different than the providers who are serving adults, but it is across the lifespan, and there is a specific inclusion of complex trauma as a qualifying condition. Iowa, New Jersey, and Oklahoma are also using health homes to address behavioral health needs for children, and are including trauma within that. Colorado, just to give us a little geographic diversity, go over to the West Coast, covers medical home navigators, and they have a trauma-informed system of care. It's a partnership between their Department of Health and their child welfare agency. As I mentioned, there's a typo on the slide, I apologize, that Maine is already there. So that they are able to bill trauma-informed services to the Medicaid program. Maine has an Adverse Childhood Experiences Foundational Series, and they are providing training to all of their healthcare providers in the managed care network. It is not mandatory, but it's actually, I believe, something that anyone can access. If at least some of it, a portion of it is publicly available. And so if there are individuals who might be interested in seeing what resources are available to providers in the main managed care program, we can certainly provide that link to you. North Carolina is also doing a lot of work in this space. So they are utilizing trauma-informed assessments and then following those up with specifically trauma-informed interventions for their adolescent population. They're not only using those tools to identify the traumatic experiences, but also to try to inform how they serve that population so that they don't re-traumatize them. And so that was rather unique. Washington State is using $1.5 million in their mental health and substance use block grants, and they're providing those grants to community-based organizations. And so one of the things that we talk about a lot around trauma-informed care, and specifically around ACEs, is that the healthcare system can't alone do this work. And so the connection with community-based organizations and increasing the awareness of trauma in our state agencies that are providing a lot of the services is critical. And so I wanted to include that work there because they're also working in partnership with their Medicaid agency. In Wisconsin, they have a managed care program called Care for Kids. It creates a medical home for children in foster care. So it is similar to a health home model, but a health home actually draws down additional federal dollars, whereas a medical home is more just the construct, the way that the program is designed. It doesn't draw down additional federal funding. But they have included trauma-informed care specifically in the treatment plans for the children who are served by that program. Also in Wisconsin is Wraparound Milwaukee, which is a long-standing managed care, it's not a managed care organization, it's called a care management organization. It's run by the Public Behavioral Health Agency, and they are bringing together, you sometimes hear the term braiding or blending. So they braid and blend funds from multiple public child serving agencies, including education, juvenile justice. I think there may also be some, there are definitely child welfare dollars in there as well as Medicaid dollars. And there are probably other funding streams that they're braiding as well. But they bring all those dollars together, and they have a very trauma-informed system there in Milwaukee. It's actually been recognized nationally. And so I think I'm at the close to the end here, but want to finish up with our final poll. And so I'll turn to Rana to lead us through this one as we close.
Sure. So this question is, which of the following do you think would have the biggest impact on reducing childhood trauma? A, increasing public awareness. B, training all child serving system providers in trauma-informed care. B, increasing federal or state funding for trauma-informed care. Or D, eliminating poverty. And please enter your responses into the chat box again.
Great,
I feel like there should be an all of the above.
You know, and I left that off on purpose. I see somebody selected it though. Yes, absolutely. And I think the intent of this slide really, everyone, is just to reiterate the fact that this is a multifaceted issue. No one sector, no one system, no one agency can really solve this problem. We have to all work together. And you're right, this is a trick question. It really is all of the above. And so thank you for your participation in that poll. I want to close with a couple of final thoughts, and I'm sure none of these are going to be surprising to you based on what I've already shared with you. But just want you to leave this presentation understanding that childhood trauma is ubiquitous. Unfortunately, it's not something that we can prevent. There are going to be negative experiences, and those experiences are going to change people. But one of the good things is one of the bright sides is that there is increasing public awareness of the issue, and there's an opportunity both in terms of the public sector and its obligation to meet the needs of children and families, the charter of our federal agency and our state agencies. And so now's the time to really pull together the folks who are working on this issue as part of their day-to-day work in the communities and in our state agencies and federal agencies, and marry that with this increasing public awareness that, this issue is now in the mainstream media, and how do we take advantage of that? We understand that our systems need to be more trauma informed, and so how do we leverage the opportunity to create more trauma informed agencies? The workforce, we know, is critical, because we may have trauma informed models and programs, but if we don't have the workforce to actually deliver those services, then we're not going to have the impact we need to have. And so we need to make sure that we have a trained workforce in place. The point about Medicaid, and I certainly alluded to this, is that while it is a critical funding mechanism, it's a very sustainable funding mechanism. It only supports the provision of trauma-informed care for a portion of the population, an admittedly high-risk segment of the population. But we need to marry the Medicaid funding mechanism with other public and private dollars. And that gives me to my last point, which is that a coordinated public-private effort is really critical to addressing trauma, both at a federal level, within our states and within our communities. And so I just want to say thank you for your attention. The last slide here has a number of resources that I think will really help folks understand this issue, both in terms of just wanting to learn more, as well as thinking about how you might leverage the work that's been done by others to do some of this work on your own. So with that, I turn it back to Rana and just say again, thank you for the opportunity to share this information with you today.
Great. Thank you, Kamala, so much for your thoughtful and engaging presentation. At this point, we'd like to open up the webinar for discussion. If you have any questions or comments, please enter them into the chat box and we'll read them aloud. Don't be shy now. If you have any questions or thoughts about the presentation, please share them with us. Okay.
And I'll just say, I know that there was a lot of information in a short period of time, so I absolutely understand that that there's a lot to absorb here.
Yep. Okay, so we got a couple. We have a couple. We have a question from Heather. Did you say the presentation and slides would be available on your website next week? Yes, we'll post the presentation, the slides, the video that Kamala mentioned, and we'll also post some of the key resources on the previous slide as well. Okay, and we have a question from Marcia. She is asking, she's saying, the stats about the prevalence of ACEs in the Kaiser study seem to not jive with the earlier ones you gave. Can you explain?
Sure. So the Kaiser study was done in 1998. The two slides that were with the purple graph and the map were 2016. So there is a pretty significant difference in time and the study population. The Kaiser study was done on that commercially insured population, and the other study that I showed with the purple slides was from the CAMI initiative, which is a child health measurement initiative. So different populations, different data sources, and different time frames.
Okay. So Kamala, I'm interested in knowing what you think is important for funders who may be new to the healthcare access and Medicaid space. What do you think are some really important things for them to know?
Let's see. So, in the trauma-informed care ACEs context, Rana?
Sure. Yeah.
Specifically?
Yeah.
Okay. So I think that one thing is that there are a number of opportunities to leverage those those federal funding sources that I included on the one slide. So there are a number of grant programs that are out there. And so to the extent that the grant dollars are going first from the federal government, I think there's an opportunity to have a better sense of what are some of the more promising and effective practices. And then maybe the healthcare grant makers can really come behind that and figure out how to engage with organizations that are working in the healthcare space to carry those things through, those effective practices through. So when I mentioned that, the healthcare can't do it alone, those other sectors can't do it alone either. And for example, those grants that are going from schools, so there are a number of grants on the education sector. They aren't necessarily thinking about the interface between health and education. And so I think that this group could be thinking about how do we leverage the work that's being done in schools to connect that to the healthcare sector. That's just one example, but that's kind of the analogy would go across multiple sectors from those federal funding sources that I mentioned.
Great, thank you. That's great. So Marcia has another comment. She states, I would have expected the commercially insured population to have fewer ACEs, but they reported more. Do you have any insights into that, Kamala?
So one thing I would say is that the ACEs study was conducted on an adult population. The CAMI findings are reports about children specifically. So those adults can look back and have a longer kind of look back period. So they've lived longer and so have likely experienced more, which probably contributes to the fact that the number of ACEs that they report individually is higher. I also think it makes a difference when it's self-report versus someone else's report. And so that could also be a factor.
Okay, great. Thank you so much. So I guess we're just about out of time. Before we end the webinar, I want to remind everyone that we'll be posting the PowerPoint slides and resources to our website next week. You can also visit the GIH website to find out about upcoming webinars and other programming. If you have any comments, questions, or ideas about future programs or topics, you can reach us at childrenandfamilies@gih.org. We'd love to hear from you. Thank you again to Kamala, and thanks to all of you for participating today. Have a great afternoon, everybody, and a fabulous Thanksgiving next week.
Thank you.
Thank you.